This is Case 7, Community-Acquired Methicillin-Resistant Staphylococcus aureus.
In epidemiology, infectious diseases are considered especially heinous, and Epi III, the dedicated detectives who investigate these vicious outbreaks, are members of an elite squad known as the Outbreaks Investigation Team. These are their stories.
I wonder if it's too quiet. Okay, where is it? Our case team is serving as the assistant to the state epidemiologist who is out of town. A high school athletic director has called to notify the department of a parent complaint regarding her child as a suspected case of community-acquired methicillin-resistant Staphylococcus aureus, CA-MRSA. Our team members are Linda Garcia, Miriam Martinez, Albessa Salinas, and Amanda Sierra. We will begin our case presentation going through a little bit of background on Staphylococcus aureus and CA-MRSA, followed by the 10 steps of the outbreak investigation, and finally, recommendations tailored to this case. S. aureus is commonly found on normal skin and in the nasal flora of individuals. Approximately 30 to 50% of the population in the U.S. has it. However, it normally does not cause health problems. In some cases, infections can develop. S. aureus has been recognized as one of the most common causes of skin infections in the U.S., with over 11 million outpatient and emergency room visits, including over 500,000 hospitalizations per year. It can also cause a wide range of infections, such as pneumonia, and infections in the heart valves and bones. Unfortunately, S. aureus has developed resistance to many antibiotics that are used to treat staphylococcal infections, such as beta-lactam and macrolides. Antibiotic-resistant staph infections have become more common and are much deadlier than previously believed, with about 94,000 life-threatening infections and 19,000 deaths in the United States. So what is MRSA? MRSA is methicillin-resistant Staphylococcus aureus. Initially, MRSA was associated with hospitals and other healthcare environments. These infections have resulted in longer lengths of hospital stays, increased costs, and increased mortality. The graphic on the slide shows the prevalence of MRSA in the United States at 55% in 2004. There are two types of MRSA. The first type is healthcare-associated MRSA, HA-MRSA. The other is community-acquired MRSA, CA-MRSA. Infections occurring in hospitals and healthcare facilities are the first type, HA-MRSA. It can occur when hospital personnel do not follow necessary hand-washing procedures. A nationwide point prevalence study found that 46.3 out of every 1,000 hospitalized patients were colonized or infected with MRSA in 2014. Community-acquired MRSA infections are MRSA infections in healthy people who have not been hospitalized or had a medical procedure within the past year. CA-MRSA entered the community in the 1990s. Recently, a dramatic rise of disease has been seen in communities. This is a major concern, as CA-MRSA strains are being shown to cause about 75% of skin and soft tissue infections among athletes in the United States. Several published reports have documented outbreaks of CA-MRSA among teams including football, fencing, soccer, rugby, and wrestling. The CDC has proposed 5 transmission factors for MRSA, referred to as the 5 Cs. 1 is crowding, 2 is skin-to-skin contact, 3 is compromised skin integrity, 4 is contaminated surfaces, and 5, absence of cleanliness. Outbreaks of skin infection caused by community-acquired methicillin-resistant Staphylococcus aureus have been increasingly reported among high school sport teams, including wrestling, basketball, and most frequently football teams. The increased risk of infection is mainly due to the sharing of sports equipment and/or physical contact between players. CA-MRSA is spread frequently in crowded areas such as locker rooms, dormitories, or crowded living conditions. Most infections occur when S. aureus enters through abrasions in the skin. Thus, a single infected athlete can cause an outbreak that can affect the entire team. As mentioned previously, the local health department was notified of a potential CA-MRSA outbreak in a high school athletic department. Our team is serving as the assistant to the state epidemiologist, who is currently unavailable. Our team knows that SSTIs are associated with MRSA outbreaks and have been increasingly reported among high school, college, and professional athletic teams. Additionally, the team knows MRSA outbreaks usually have an incubation period of 1 to 10 days after infection. Our team used a 10-step CDC approach to investigate this potential outbreak. The first step our team took was outbreak recognition. The case started with a male student with a painful swelling on the anterior aspect of his left leg, where he had been healing from a previous abrasion. He is running a fever and has developed shortness of breath over the weekend. He was evaluated by an emergency room physician at a local ER, where cultures of the skin infection have suggested this organism is Staph aureus. The athletic director is concerned that the boy contracted this disease at school or during practice. The next step was to verify the diagnosis and confirm the etiology of the outbreak. The ER personnel confirmed clinical appearance of SSTIs and performed the necessary laboratory tests. It was also found that the male athlete was involved in high-contact sports when the abrasion occurred. The athletic trainer did treat the initial wound at school, but the male athlete did not practice good hygiene and did not treat his wound at home. The athletic trainer did not state the hygienic regimen of the athletic department. Step 3 was to identify cases and establish a case definition. The clinical features present in the first case were shortness of breath, fever, and a painful, swollen abrasion. Laboratory suggested S. aureus by positive cultures of skin infection. Thus, the case can be classified as confirmed. The individual has typical clinical features, and there is laboratory verification of S. aureus. Cases can be identified through the clinical presentation of skin infections. Staph skin infections cause a red, swollen, and painful area on the skin, including drainage of pus and other fluids. Oftentimes, MRSA can be confused to be a bug bite, rash, or other skin condition. Symptoms of MRSA are red, swollen, warm, or tender sites. When a skin infection spreads, or no improvement with after 2 to 3 days on usual antibiotics, it may be MRSA. The following step was to collect data. This included epidemiological verification, laboratory verification, and data collection. Epidemiological verification was done through finding cases of skin lesions, identifying all potential cases at the school, and determining the scope and magnitude of the outbreak. Laboratory verification was through ER confirmation of cases who were in close contact with the first confirmed case. Our team distributed questionnaires asking about exposures such as, do you play sports? And do you take a shower after practice or games? Obtaining medical records as necessary, and conducting interviews. Step 5 was developing a hypothesis. The leading hypothesis formulated by the investigation team, beginning with information known about CA-MRSA, tests, and following interviews with the students, was that CA-MRSA skin and soft tissue infections were due to abrasions with poor hygiene and equipment sharing among high school athletes. Finally, the data collected was analyzed to evaluate the hypothesis epidemiologically. The data was organized and analyzed to create and assess the timeline, epidemic curve, and infection rates. Data was then summarized regarding time, place, person, and risk of contracting CA-MRSA. As part of Our team continued the investigation by implementing control and prevention measures,
and
additional studies included controlling the source, transmission, modifying the host response to exposure, and establishing policies. For Step 9, our team will continue to monitor the CA-MRSA situation and determine whether the prevention and control measures are working. We will ensure no new cases are emerging. If new cases do emerge, we will determine if the new cases are from the same location and exposure, or if this is a new outbreak. We will also ensure that the outbreak has been controlled from original exposures and locations, and we will determine if additional measures are needed. Lastly, we will document the effectiveness of the control measures. Finally, the findings will be reported. The team found that the MRSA case did originate at school, but exposure risks were exacerbated by improper wound care and personal hygiene. These findings will be reported to the mother of the student as well as appropriate school personnel, such as the nurse, athletic director, and school board members. Additionally, general findings about prevention and to raise awareness of CA-MRSA will be posted on district social media pages and reporting to the local newspaper. In addition, newsletters and fact sheets will be sent to parents of students at the school. We will also present the findings at the high school athletics orientation, re-emphasizing the recommendations to prevent and incorporate the preventive measures and policies, increase awareness of CA-MRSA and transmission, ensure adequate cleaning, disinfecting of facilities and equipment, educate trainers, nurses, other key personnel to identify potential cases and to help reduce them, emphasize the importance of cleanliness and hygiene, ensure that. Thank you.